All right, so good evening, everybody, and welcome to our program tonight. I'm Brenda Goldfarb, the Adult Programming and Outreach Coordinator at the Cornwall Public Library. Tonight, we're partnering with Montefiore St. Luke's Cornwall and Prostate Cancer Awareness Month. But before we begin our program this evening, I wanted to share two other programs that we're partnering with. One of them is on October 18th on the latest information on COVID-19 vaccines, and it's on October 18th. And then on October 28th, we're doing a program for breast cancer. We ask you to please go on to our website, go to the calendar, click on the date. It'll take you to the Montefiore St. Luke Cornwall website, and you can sign up. It's not only valuable for you, but please pass it on to your neighbors as well. Lots of good information. Okay, but tonight we're very, very fortunate to have the opportunity to learn and listen from one of Montefiore St. Luke Cornwall Hospital's finest. Dr. Pranith Vemapalli, also known as Dr. V, is a board-certified urologist. He received his medical degree at Tufts University School of Medicine, with research. He completed his surgical and urological training at SUNY Stony Brook University Medical Center, Ohio State University Medical Center, where he was awarded the prestigious clinical fellowship in robotic urologic surgery for 2011 to 2012. Dr. V treats all areas of urology with a keen interest in minimally invasive and endoscopic surgery of the kidney, bladder, and prostate. He has contributed papers and textbook chapters in the field of urology and minimally invasive surgery. Please stay muted. Please post your questions in the chat room. Dr. Vemapalli's contact information is in the chat room. And as time allows, we'll try to go through as many questions as possible. So, Dr. V, it's all yours.
Well, thank you very much, Brenda. Thank you for that terrific introduction. So everybody, this is a Prostate Cancer Awareness Month. So here at St. Luke's, we wanted to try to do a program for the community to talk about what prostate cancer is all about. How do you screen for it? How do you try to prevent it? What's meaningful about it? What's not meaningful about it? And what are the risks and benefits of doing it? Because there's some benefits, but there could be some downside risk. And what does that mean? And so I tried to make this talk pretty even-handed to go over the pluses and minuses of everything. What are some of the things that we can do to treat patients with prostate cancer? And really, it's for the community, so it's designed to answer any questions that are out there. So I want to give you time to meaningfully address any concerns or questions or misunderstandings you might have. There's a lot of this sort of thing. Prostate cancer, as I know personally, is advertised quite often in either magazines or on TV or in commercials or radio. And so there's a lot of information out there, and some people can get confused by the different information and what some of the terms mean. So if there's things that you're not certain about or would like to have some clarification on, this is geared towards answering those questions. So I encourage you to voice any of those type of questions. So just to get started, the purpose of today's talk is to give an idea of what it is that we'd like to accomplish. Just try to give you an overview on what prostate cancer is, where is the prostate anatomically, how do we identify it, how do we treat it, things like that. And in order for screening, what's the importance of proceeding with prostate cancer screening? How can it benefit patients? Why might they be interested in it? And what's their role? And that's something I'd like to kind of go over as well. First of all, anatomically, what is prostate cancer? Prostate cancer is something that arises in the prostate gland. And anatomically here, as you can see in the red box here, it is a gland that sits underneath the bladder. It often has a channel where the urine passes through. Oftentimes men can get benign growth of the prostate, and that can cause some urinary symptoms, urgency, frequency, poor stream, things of that nature. It's anatomically below the bladder in front of the rectum. So typically we examine patients with what we call a digital examination, and that's we use our finger to palpate the prostate and the rectum. It can vary in size of what's normal. We call it about 20 grams or so, and that's usually about the size of, a small golf ball or a small walnut. It serves the biological function of creating some of the seminal fluid, which is used for reproductive purposes. I think I had a slide on here, maybe that that sometimes I guess didn't make it through. So basically, I have a slide here that just shows how prevalent prostate cancer is. Approximately, there's about 20,000 men a year that get diagnosed with prostate cancer. And some of those folks have different degrees and stages of prostate cancer, where many times it can be weak type of cancer that's really not going to affect them biologically. And other folks can sometimes get a more aggressive variety that can at times spread to other places and would benefit from some therapy. These are just some estimates. In prostate cancer in the United States, this is going back a few years, where I found some data about 240,000 new cases of prostate cancer are going to be diagnosed. Of those patients that are diagnosed, about 37,000 typically in this calendar year would end up passing from that as a diagnosis of death. In New York State, that's what I was referring about. There's roughly about 14,000 new cases and roughly around 1,600 deaths attributed to prostate cancer. Age is what we consider to be the strongest risk factor for men that develop prostate cancer. Statistically, about 63% of prostate cancer cases occur in men over the age of 65. But what I'd like to point out with this is typically a bell curve. Typically, we start screening patients for prostate cancer when they turn 50, and that's usually done with a digital examination, as I mentioned, but also a prostate cancer blood test called a PSA. And the reason I like to call this a bell curve is that though the majority of patients fall into this age range of where they might prostate cancer might occur, we oftentimes detect prostate cancer in men in their 50s and a few times in their 40s. And similarly, we oftentimes can find patients well into their 70s or 80s where we start seeing the signs of prostate cancer. And some of the reasons that we check it is that also if there's a family history of prostate cancer, particularly a first-degree male relative, father, brother, uncle, somebody like that, then that kind of makes us kind of more attuned to figure out, hey, there's a family history here. There may be a genetic predisposition for prostate cancer. Not that there definitely will occur, but just kind of lets us know that this might be a patient that we need to pay a little extra attention to, review their numbers, check their examination, make sure that gets done. Again, there can be sometimes, and I've had personal friends of mine that have had prostate cancer develop in their 40s. So this can affect patients at all around the spectrum, but statistically, we start checking patients for prostate cancer when they turn over the age of 50. This is just an interesting study that I brought up, and I found this is from the Maryland Cancer Registry. And I think what's really important, or what I wanted to highlight with this study, is that there's a higher predisposition of prostate cancer in African-American males as opposed to other demographics. And you can see here, this line with the orange, you can see it's the highest there. Prostate cancer has a higher predilection in African-American communities for an unknown genetic reason, but we know that African-American men oftentimes can develop prostate cancer at a higher prevalence, but oftentimes those that do get prostate cancer many times can develop a more aggressive variety of prostate cancer. So that's a particular demographic that we're always very interested in screening because of this fact. Why it occurs, we don't exactly know why, but it is something that we've identified. Oh, did I go backwards? Again, this is just that race is more common in African-American men than other races. And this is just an incidence and mortality relationship. And you can see that this bar graph is comparing per 100,000 males. You can see that the occurrence of prostate cancer in African-American males per 100,000, the incidence is about 232 cases, of which the mortality is about 56 of those patients. And you can see that as opposed to Caucasian men, per 100,000 males, the incidence is about 146, which is slightly higher than in Hispanics compared to Native Americans. And then the last group is Asian Pacific Islanders. And this is something that we know for whatever reason, prostate cancer, these are statistics in American populations as well, compared as opposed to patients in Hispanic patients in different countries or different things. We know that there is some correlation with American populations, and this is reflected to American populations only. So African-American men, Caucasian, white American males, so on and so forth. So again, risk factors for prostate cancer, as I mentioned, hereditary findings. If you've had a father, a brother, an uncle, that means that there might be a higher risk in your particular case. So that's just another reason for why, because there may be an increased risk, that we recommend these patients follow through with screening. And sometimes if there is a significant family history, father, several brothers, uncles, then we might even start screening earlier at around 45. And so this accounts for about the 5–10% of prostate cancer patients. Other areas that we're not sure but can definitely occur, we've seen patients with significant obesity, diabetes also get more aggressive prostate cancers. And why that is, we're not exactly sure. So again, for the lifetime risk of prostate cancer, in African-American males, it's about 19%. So about 1 in 5 have a risk of being diagnosed with prostate cancer. This doesn't refer to mortality, but the incidence of prostate cancer. And as we get in, prostate cancer has aggressive varieties, and it has, less aggressive, very low risk varieties. This just refers to the incidence of occurrence. And of that 20% that potentially have a chance of developing prostate cancer, there's a 5% chance, or 1 in 20, of dying from prostate cancer, as opposed to the general population, which has about a 1 in 6% chance of being diagnosed with prostate cancer, and similarly a 3% chance of death. So you can see again that this is basically designed to highlight the fact that this disease occurs more frequently in African-American populations, and oftentimes can be more aggressive in those populations as well. Symptoms of prostate cancer, there really are none. And I think this is something that patients will ask me quite frequently, how do I know if I'm developing prostate cancer? With most things like this, when we're designed to screen patients, we're trying to identify these patients before they have a problem. So they might not necessarily have any complaints. Otherwise, men may look fine, feel fine. And that's really why we call it screening. And I kind of equate this to patients that get screening colonoscopies. And usually they get that before they have any symptoms of abdominal pain or blood in the stool. Similarly, for prostate cancer, we screen our patients with annual physical exams, with digital examinations, as well as yearly PSA blood tests. So there may be no signs of prostate cancer developing, particularly in its early stages when it's most treatable. If there are signs, what could they be? Possibly it could be blood in the urine. There are some signs of prostate cancer that overlap with benign disease, such as that BPH that I mentioned earlier. Some of those symptoms could be the need to wake up many times at night or to pee frequently during the daytimes, having complaints of a poor urine stream or interrupted urine stream, discomfort, pain with urination. Sometimes in other cases that they're unable to pass urine altogether. It's called urinary retention. And again, that can be due to benign conditions sometimes, but also could sometimes be due to prostate cancer that's been left undiagnosed or is progressing. At times also pain in the lower back, pelvis, upper thighs. In cases where prostate cancer is spread, sometimes it can go to the bones and it can present with pain along those areas and along that part of the skeletal. So ways to that we as urologists, and sometimes it's your primary care doctors that screen patients for prostate cancer or patients that might have a higher risk, is number one with a blood test that stands for, and that might be a test that some folks are familiar with called the PSA, and that stands for prostate specific antigen. And that's a normal protein that's produced by the prostate gland. PSA is normally exists at certain levels in the bloodstream, and depending on what that level is, if it's within a certain range or if it's outside of a certain range, that might, cause concern that there might be some prostate cancer developing. And a digital examination, as I mentioned before, and that's designed to feel the prostate through the rectum to see if there's any nodules, texture differences, things of that nature. What else can increase the PSA level? So many times patients may have a PSA number that's elevated beyond normal. And sometimes that could be just due to the size of the prostate gland. If there's any, obviously, I'm sorry, for the sake of this talk, obviously if the PSA is elevated, we're concerned for prostate cancer, but sometimes it could just be to benign growth of the prostate, and that's called BPH, or benign prostatic hyperplasia. And that sometimes is growth of the prostate. And as the prostate gland grows, there can sometimes be inflammation that develops inside that channel, and that can be an obstructive component to the passage of urine. And that inflammation that develops from that obstruction can sometimes lead to an elevated value in that PSA blood test. Age, some men typically tend to have PSAs that increase with their age, and that may also have some underlying component in cross activity with the growth of the gland that occurs as men age. Other conditions that can cause the PSA to rise are active infections. Before we mentioned inflammation of the prostate that can occur with urinary obstructive complaints, but prostatitis is an infection of the prostate, usually a significant inflammatory reaction due to that infection, and that usually can elevate the PSA numbers quite a bit. So many times if we see a patient that's presenting with complaints of prostatitis, pain, what I call in the bicycle seat area, burning, discomfort, poor urine stream, a lot of times until that acute phase has passed, we might not actually check any PSA numbers because oftentimes it can be falsely elevated. So typically also sometimes ejaculation can increase PSA levels for a short time. And typically if men have a concern about PSA elevation, we ask them to abstain for ejaculation for at least 2 days before testing. Factors other than prostate cancer essentially can increase PSA. So just sometimes I try to tell patients that just having an elevated PSA may not be anything to set off any alarms. Typically it's one variable that's outside the range of normal, and we typically like to get more than one variable. So oftentimes if one value is elevated, we might just repeat that number at a certain point, make sure there's none of these conditions like prostatitis or infections going on, and then repeat the number to see if this is a realistic number or could it be just an outlier. Screening for prostate cancer. This is something that, I've had some patients speak to me about because they found that there's been a lot of discussion in the lay literature and even in some medical journals about the usefulness of PSA testing. Prostate cancer can oftentimes be present in folks as they get older, and many times it's a low-grade variety. So as I mentioned in the outset of this talk, what's the risk versus benefits of screening for prostate cancer? And in this particular study, they were looking at could there be excess harm from screening patients for prostate cancer and treating prostate cancers that may or may not necessarily need to be treated. So what are the possible benefits of prostate cancer? A man based on this this study, they said that 1 man in 1,000 at most may avoid death from prostate cancer because of screening. That was based on this analysis. But I think what was one of the fallacies or something that was wrong with this study and this analysis was that they were comparing patients that had been screened with patients that had also been screened. And so in this cohort, typically when we examine patients, we check a PSA and a digital examination. And if there's an abnormality, if there's a nodule, If there's an elevation in PSA, we would further evaluate those patients. Similarly, in this cohort of patients that were being analyzed, the comparison was being made between patients that had a PSA test as well as a digital examination compared to patients that did not have a PSA but did have a digital examination. So there were patients that were removed from this cohort that were screened out for prostate cancer because of an abnormal physical exam finding. So I think some of this data is not entirely accurate because of that. So sometimes, with prostate cancer screening, sometimes the PSA number can be high. And if it is high, sometimes we recommend treatment. Either that could be either a prostate biopsy, and sometimes that could result in an infection, which is low, typically about 1%, but also based on this task force analysis, they said that treating patients that had prostate cancer could sometimes lead to problems with erectile dysfunction, urinary incontinence, and that's certainly possible. If they were having surgery, that 2 men out of 1,000, there's a chance for developing a serious cardiovascular event, such as a heart attack, and could also develop, one person could also develop a blood clot in their legs or lungs, and that's also a possibility anytime, particularly if someone has surgery or has cancer, they're at a higher risk for developing blood clots. And they said that for every 3,000 men who were screened, that one could potentially die from complications from surgical treatment. And that's, of all the risk of patients, they could have pneumonias, blood clots in their lungs that travels to their, blood clots in their lower extremities that travels to their lungs, or has an acute cardiovascular event. These are all possibilities that could happen. And so those are some of the risks for prostate cancer treating. Again, what I'm trying to do is try to give you the benefits of identifying disease to try to prevent mortality, but yet also undergoing therapy sometimes has its own set of risks, and those are the two treatment arms to compare. Can prostate cancer be prevented? We don't have enough information to really answer this question well. Some things that we know is that in different demographic populations, as I said initially with, that slide I had with African-American men, Caucasian-American men, there's a higher predilection of prostate cancer in America as opposed to Asian countries like Japan, for example. So there is some environmental component. What exactly is that, and is that multifactorial, is still being investigated. So for patients that do have prostate cancer, one of the things that we do is we treat it for aggressive disease, either with radiation or surgery, and we have both of those modalities available here at St. Luke's. One of the things that I do personally is robotic surgery for prostate cancer, and that's used what's called the Da Vinci robotic surgical system. And it's sort of similar to what you see here, where on the left-hand part of your screen, there's a console where the surgeon is operating the instruments, and the diagram in the middle is the robot itself, which is basically under that surgeon's control, is able to manipulate its arms. And that really gives us a three-dimensional articulation inside of a patient that is far superior than to traditional laparoscopy. These are some of the instruments that we use inside to accomplish our procedure. Some of these are grasping tools, some of these are cautery agents, some are scissors, some are retractors, but they're vessel sealers. So typically, when I started doing this, not all of these instruments are available, but as with everything else, the technology and the ability to do what we do through smaller incisions with better hemostasis and better dissection seems to be improving year after year. And this is the traditional typical port placement to accomplish this procedure. So traditionally, surgical therapy for prostate cancer and aggressive prostate cancer, because it's confined into the bony pelvis, it has a high vascular component, would be prostate cancer open surgery typically was fraught with significant blood loss. Many times patients would have to donate blood before surgery, or they would have large amounts of blood loss during the procedure, need transfusions afterwards. And this was not due to any abnormal or unusual circumstance. It was just related to how do you manage this sort of a surgery within the confines of the anatomy and the location in the pelvis. That has significantly and dramatically improved with the use of the robotic system, in the sense that I feel very confident saying that transfusions themselves are extremely rare, less than 0.5%, I would suggest. Certainly, it's been our experience here. And so this is the anatomical reason for why that can happen sometimes, is that what is a diagram here is it's an anatomical diagram. It's a Netter picture, which is one of the diagrams that medical students use when they're learning anatomy. And you can see the tributaries of vascular flow that go to the prostate in the confines of the bony pelvis. And sometimes this area can be difficult to access because of the pelvic bones as well. This is kind of the view that you get with the robot. So as you go between these two pictures with the robotic system, you're able to really get right on top of where this blood supply enters and do a really fine dissection with the ability to insufflate the abdomen that just is not as capable in an open procedure. So you're able to really get the magnification, almost like on your phone, as you can zoom in on something, you're able to zoom in with the camera to really do fine dissection. And that's really what's, I think, advanced our ability to treat this disease. And we're also able to really identify the areas of the sphincter. So some of these things that were very common and still can occur with incontinence are a little bit less, because we're able to do such a fine dissection. And that's identifying the area in this particular diagram of the prostatic apex, trying to save as much of the prostatic membranous urethra and the rhabdosphincter that is able to provide continence after this procedure. What's the role of, basically, I think the role of me being here and trying to talk about this is that some of this stuff can be scary. It's hard to digest, verbiage and terminology that, people like me can throw out very easily, and it's almost like voluminous. And so realistically, the purpose of this is to try to make some of this information as digestible as possible. And I try to talk to patients that, if you get a diagnosis, whether it's any cancer diagnosis, just try to breathe, take a deep breath, take it one step at a time. What we're trying to do is we're trying to educate you about what is it, what grade of cancer could a person have, what stage could it be, what are the treatment options, and all that is, a lot of information to just be thrown at somebody, but also to be able to absorb it, to understand it, to digest it, to then make an informed decision. It takes a certain amount of time and ability, and it's scary. So it's hard to do that when you're on your back foot, when your breath is taken away. So just the purpose of this is just try to present some of this information so that people have an idea of what it is. So therefore, when you see certain things or information on TV or on the internet or other places, it gives you a scaffolding and a background to be able to process some of that information that, this be out there, but it's not as scary as it seems. There are a lot of things to do, and what are the outcomes, and how do you make your decision? So basically, we're just trying to educate you in order to give you some of that information, to give you some of that scaffolding to be able to make a decision that you're comfortable with. Also, just trying to let people know what are the risks of prostate cancer. So if you do have like family history, is it something that, you might yourself might have children or family or things like that. And it's important that, you get evaluated, get checked out, so that if there is a risk to you, that you can properly manage that risk. And if you get some of these, if you see all of a sudden you get on a blood test, you're having a normal physical and your PSA number runs high. What does that mean? Is that really worrisome? What could that mean? Do I have cancer? And that's just to give you a scaffolding. Sometimes these numbers can be, wonky and not be realistic. And, we just repeat it. And so a lot of times when I repeat it, a lot of these numbers go down, but sometimes they don't. And those need to get looked at more closely. and the decision to get screened. There's some negative outcomes for doing some of these screenings and procedures, infections and things. And, doc, is that for me or not? I think that's a decision each patient should make with their individual doctor. But to know about what they are, to be able to quantify that, the risk of doing something versus the risk of not doing something, that's a personal decision, and nobody's trying to impact anybody else's capacity to make that decision, but it's just something that we want you to be educated about. And so basically, we just want you to be able to, if this is a concern, that you'd be able to have a reasonable discussion with your own personal doctor to go over the risks and the benefits, and is it something you should consider or something not to consider?